Thank you. Good evening, everybody. It's a pleasure to welcome you all once again for our Pan India ILD multidisciplinary meeting. And as you are aware, we have incredible group of experts, which comprises Professor Athol Wells and Professor Katrina. So great to have you here, along with our Murli Mohan sir and Prahlad Prabhu Desai sir, who are our pulmonologist expert, and my dear Mithun, who will be always willing to help us out in spite of his busy schedule. And thank you, Aparna, for joining us today. We have got 6 cases, and as you are knowing that we have got a busy day, we will just directly dive into discussion without wasting further time. Uh, our personal thanks to Dr. Prakhar Sharma, who is now become regular presenter over our MDM, and his cases are very interesting. He has come with 2 cases, followed by, because Aparna has arranged it like that, Murli sir. So I will be presenting third case, and your case will be fourth, and last 2 cases will be Rajan sir. So over to you, Prakhar. I will start sharing my screen, and you can start presenting.
Sure, ma'am. Thank you.
One second. Yeah, it's more
Sure, ma'am. Good
visible,
evening,
right?
everyone. So our first case is a 43-year-old male. He's a chemist and a non-smoker, doesn't have any comorbidity, and he presented to us with shortness of breath and dry cough symptoms since 3 years.
Sorry. Yeah.
So he just had these 2 symptoms. There were no systemic symptoms, and there was no exposure history per se, and no connective tissue symptoms as well. On examination, his vitals were all stable. Respiratory system examination along with cardiac, CNS, abdomen, musculoskeletal, dermatological, and ocular were normal. On investigations, again, most of his investigations were within normal limit, except for serum ACE, which was just about on the higher side of the normal range, and nothing specific. His echo as well as was normal with no features of pulmonary hypertension. Even his spirometry, it showed uh, just some amount of mild restriction, nothing else. The LCO was adequate. His 6-minute walk test also revealed 417 meters of walking distance without any desaturation. So based on his radiology, we went ahead with a BAL. BAL again was negative for all infective workup. The TLC was 300 cells with predominantly lymphocytic character. Cytology malignant cells were negative. His bronchial mucosal biopsy revealed us as granulomatous inflammation, and there was no caseous necrosis, while TBNA was non-conclusive. Uh, I have just added these radiographs of the CTs because, sorry, images of the CTs, as these are way old, of March 23, where we can see there are, I think radiologists can discuss this, but it has been added just to show that the lesions have been static. Over this time, he had received 6 months of ATT as well. So when he visited us, we, based upon the granulomatous character of his interstitial lung disease, we considered him to be sarcoidosis and started him on steroid with 20 mg and gradually tapered him over a period of 1 year. He responded very beautifully to the clinically. All symptoms almost regressed within 2 to 3 weeks of starting the treatment. However, after stoppage of treatment, he again visited us within 3 weeks with same symptoms recurring. And an HRCT was repeated, which I would like
Yeah,
our
yeah.
radiologist
Sure,
to
sure, sure.
discuss.
Yeah,
Hmm.
Aparna can. Why was TB medicine given, Prakhar?
That
Meanwhile.
was given from the outside, ma'am, considering based on clinical radiological basis
Okay.
only. There was
Sure, sure.
no positivity.
Okay, fine. Aparna, you talking? We cannot hear you, or you are not talking.
Oh, no,
Yeah.
sorry. Yeah, I was muted.
Yeah.
Yeah, we have HRCT from 16th of January and one PET-CT, which is from 15th of February.
Sure.
So, and I think the others are like Sir showed in some specific pictures, which I did not put up. So just the photos of the previous CTs.
Sure.
So on the 16th January, what we can see is basically perilymphatic nodules. Many of them are clustering and becoming confluent centrally, and it is having an upper lobe predominance, and the lung bases are relatively spread. So it's a typical perilymphatic nodules. And in the mediastinal window, we can see a lot of nodes which are showing calcifications. I'll just get it up.
Yeah.
So these are the nodes which are showing calcifications. It's not really eggshell-like, but some kind of an amorphous calcification. The pulmonary artery is within normal limits, not dilated. And in the liver, there are few small things which I think are more likely to be cysts. And spleen does not have any lesions. These are the liver lesions, which I think are more like cysts. So basically, the radiologically, it is looking very typically like sarcoidosis with the perilymphatic nodules. And the second one, which is the PET-CT, is almost similar. So, and the uptake on the PET is mainly in the lung lesions and not much uptake in the nodes.
Okay.
So we don't have any image where it is showing radiological response, no, sir? It's
No.
clinical responses there. Okay.
So that is the strangest thing in this case, that despite having received therapy over a year, he hasn't responded radiologically anyway.
Hmm.
So, but you said he had responded and now he has come back with the relapse, no? So
Ma'am, he
this is
had
a
responded
relapse CT, or
clinically. Yes.
this is the CT with the relapse. So we don't actually have a CT at the end of treatment, no, sir,
No, ma'am.
to say
However,
whether he
it's
had a response or
this
not.
CT is very, very close to almost a month near to the end of the treatment.
Okay.
Moreover, this CT is absolutely similar to the ones that he had in 2023 as well as in 24th December. Sorry, 23rd December.
Yes. But I think radiologically and pathologically, it is very much
Same.
corresponding to sarcoid only. And
Yes, ma'am.
yeah, I don't know why it is relapsing so quickly.
So I think
Yeah.
we can go
No
to the
problem.
questions and
Questions. Sure, sure, sure.
yeah.
I'll just share the screen if you have put the questions at the end. Yeah.
So
So, yeah, you can
in
summarize.
summary, he's a 43-year-old chemist who has symptoms of shortness of breath and dry cough since 3 years. On examination, there's no significant finding. Even the labs, as well, the BAL just revealed 300 cells with lymphocytic character. On mucosal biopsy, they were non-necrotizing, endobronchial mucosal biopsy, they were non-necrotizing granulomas. He had received ATT prior. This time he received almost a year of prednisolone over a tapering dose, but radiologically has remained static and now sort of symptom increment again after stopping steroids. So my questions to the panel is that why possibly, what possible reason could we think about why the lesions might have remained static? And now considering that it's sarcoidosis per se, should this patient be restarted on corticosteroids or a second agent like methotrexate, or this time we should go ahead with the dual agent therapy?
Any chance you repeated S level?
Uh, Ma'am, we had asked him, but somehow we do not have the report by now. Matlab, he did not
Sure.
get it done actually.
Okay. We can start with Murli sir or Prabhu Desai sir. So his question is whether we should treat, and if we treat with what? Restart steroids or dual agents or
Treatment, we'll have to go ahead with a lot of.
Shall I just comment? I mean, we do start treatment for organ dysfunction in sarcoidosis, not for the radiological changes. Would you mind just letting me know what is the organ dysfunction? What is the lung function decline at the moment, and is there any way of organ dysfunction in sarcoid in this patient, please?
So we have asked this patient to revert to us. The CT, etc. we have had by our telephonic conversation actually. So we have asked him to come back to us and get all these pulmonary function testing done.
Thank you.
But even in that case, there's a lot of granulomatous inflammation, and sooner or later, I suppose it's going to injure the lung if we allow it to remain. That's what I think.
Yeah, I think, I'm sure that the panel will kind of further give their input, but we do not consider much about the radiology in sarcoidosis. We are more concerned about the organ dysfunction, actually, and they are the usual treatment
The
targets.
quality
And
of
we,
life, yes.
yeah, so
We
yeah,
have
that's
Athol here, so I think we have to listen to him because I think this is Athol's
Yeah,
law of
sarcoidosis.
quality
Yeah.
of life versus organ damage. So I think
Yes.
Well, let
Go
me
ahead.
say firstly, there's nothing wrong with following with chest x-rays. So you say that the radiology is static, but you got a snapshot before you treated and then a snapshot after you withdraw treatment. And clinically, he's relapsed when you get the second snapshot. So you don't actually know that the abnormalities were static. Whether they were static or went away and then came back when treatment was withdrawn hasn't been answered, but because he improved clinically, I'd be very surprised if a simple plain chest x-ray would not have shown major regression of something obvious on an x-ray. So I don't think you have to always go to CT scans and not do imaging in between. So I'm going to assume what seems likely, that your clinical response was actually meaningful.
Yes.
With regard to lung function, it's the fact these are nodules that's interesting. When we've broken down CT abnormalities against lung function impairment, nodules are often functionally silent. But I must say that this is very impressive nodular infiltration. And I'm a bit surprised that the DLCO was 105%. But that's sarcoid for you, and whoever said it, it's not so much the imaging. So you're coming to quality of life, and you've told us that the symptoms relapsed, right?
Yes.
So you do have a bona fide reason on quality of life grounds to reintroduce therapy. I think we should take aboard a move that's happening as we speak across sarcoid. Belatedly, there will be a shift in sarcoid to reflect what has happened in connective tissue disease, which is to try to minimize the duration of steroid therapy. And that's because of the tsunami of long-term comorbidities, some of them with a mortality, related to steroid prescription in the long term in sarcoid. So the goal of an initiative happening right now is to promote no more than 6 to 9 months of steroid whenever possible. And I think it is very logical to introduce methotrexate at this point. Now, if the patient is telling you the symptoms are so bad, he has to have a quick response, then it's reasonable to negotiate and say, okay, we'll give both some steroid to begin with and methotrexate. And this is going to be patient-centered, isn't it? You're going to make a deal with the patient. And there are some patients who will say, I've got to get the response in the next week or two. Well, you're not going to manage that with methotrexate. So I think it is reasonable, if it is that scenario, to combine steroid with methotrexate, but it's got to be with a goal to get the steroid out as early as you can, because you don't want to wind up in long-term steroid in this patient. It's better to wind up with low to moderate dose methotrexate in the long term, given all of the comorbidities with steroids. Okay, I think that's all I can think to say.
Sure.
Can I say something about
Yes, yes.
this?
Yeah, please.
Yes, I fully agree, of course, with Athol about this approach. What I do not capture very well is that, as he said, DLCO is very high. I don't remember the FPC, which is more reproducible measurement. And we have to take also in consideration, as the symptoms are not very specific and the sarcoid can do anything, everything. I think that also we have to be sure that the symptoms are related to the disease and not other diseases or other comorbidities. So that's why we have to, to balance, because if the lung function test is so well preserved, we have to concentrate to be sure that the symptomatology is related to sarcoid with so high DLCO. So I'm just asking because I don't remember the FVC and the main symptoms that he, says about his disease and the other diseases.
FVC was 2580 ml in the beginning, ma'am. That is called minus 2.46.
Yeah, if you could do a percentage of predicted simply because one's used to working with that. But you are saying there's some restriction there, basically, with a normal gas transfer. It's a very good point, but we've got to keep in mind that the dyspnea and cough vanished with steroid and reappeared when steroid was stopped. So
Yes,
I think that doesn't apply. And I think
Yes.
if there was cardiac sarcoid, which is your other explanation,
Indeed.
the PET scan would probably, well, should have shown signal in the heart, I think. Now, could it be cardiac sarcoid that's burnt out? Well, I guess in that case, why would the dyspnea have gone away with steroid therapy? So it's difficult to say it's another sarcoid effect other than in the lungs, I think.
Yes, of course. I would like to say just this part that if the FVC is very well preserved, I would like to be sure to exclude cardiac sarcoidosis or some cardiac involvement, cardiac failure or something like that, because it is also very evident on the CTs that it was a sarcoid florid. So that's why I thought that the FVC should be also preserved in these patients, but also in this patient with so much well preserved DLCO. Differently, I would like to be sure that the patient does not have other comorbidities within or without sarcoidosis that have to be taken in consideration in order to decide the two lines of therapies that you suggested, and I fully agree with you. That's why I was asking. And I also think that he had a very florid sarcoidosis. So, of course, also the response to steroid, it should be related with the disease, with sarcoidosis, because it is also something that we have to ask the patients, the patient regarding the disease behavior classification, because also the response to steroids, it is showing us that it is something related to his or her disease. But I don't know, for example, how are the airways of these patients, for
It's
example.
the ratio is restrictive, or rather,
But sometimes also
there's
in
more
restrictive
FVC reduction than FEV1 reduction.
Yeah.
Can I just say those parameters seem to have been inverted? You've got a higher FEV1 than FVC, which is clearly possible.
Yes, okay.
I don't know
But
which got inverted.
the other issue is that sometimes also in restrictive disease, you cannot be sure of the bronchial hyperresponsiveness because it is something that you can see in sarcoidosis patients and very close to asthma, how they react, even with restrictive disease. And I don't know, for example, the auscultation of the patient, because it is also related sometimes to some airway involvement that steroids could also help in this situation. So that's why I'm asking all these questions, because it is a very big decision to start steroids. according to my
Sure.
opinion.
Well, I think you'll get fairly clear answers from talking to the patient, because if it's a bronchial hyperreactivity, the dyspnea won't be reproducible or similar day by day, and the patient will describe wheeze rather than panting for breath. So the account given by the patient will generally sort that out, I believe. Look, you've got to come
But
back
you
to
have
the
to ask
fact.
the
You've got to come.
patient,
You've
because
got to come
sometimes
back
the
to the.
patients
You've
do
got to
not
come
say
back.
to
You've got to
them.
come back. You've got to come back to the fact that the steroid removed the symptoms completely, and then when the steroid was stopped, the symptoms came back.
Dr.
So
Asmita, can we have
once
the lung functions back, please? Sorry, Professor Wells, I just wanted the slide up again. Please go
I'd
ahead.
like it to. I'd like it as well.
Yeah, so here the FEV1 is described as 3.7 liters and the FVC
Right,
is.
so
We need to, invert those. And I don't know about the Z scores. Which is the Z score related to? So if that is the FVC Z score, then it is clearly very restrictive.
but the ratio isn't.
The
Yeah, ratio is wrong. Okay.
So somebody's used the FVC normal predicted for an FEV1 that was measured. And so if anything, this is slightly obstructive, isn't it?
It is. Which is why I think what Professor Katerina is saying is true. And I completely agree with her. We need to look at the heart also. But again, as Professor Wells said, steroids with methotrexate or just methotrexate alone after discussion with the patient. I think
Yes.
that's pretty clear.
I
Sir,
think
on
we'll
the
move
PET,
on to the second case because, we are.
Sometimes I would like to say that it is good to listen also the chest, because sometimes the patients do not come to say to you, I have wheezing. You have to ask them, and this wheezing in sarcoidosis is a little bit bizarre sometimes, It is not always wheezing, a clear wheezing. So that's
Yeah.
why we have to listen also to the chest. We don't have to forget this.
Sure.
I just wanted to add that on the PET, there was no cardiac uptake.
Yes,
No, we took that aboard, but the issue might be if the sarcoid had been there for some time.
Yes, sir. Yes, sir. If it is burnt out in the heart, we won't be able to see it.
Yeah, but I think in that case, if the breathlessness was cardiac, it shouldn't have gone away with steroid therapy. So if there was scar tissue in the heart, it shouldn't have gone away.
Yes.
So I very much doubt there will be cardiac sarcoid, but as a matter of routine, it is correct to get an echo done in a case like this and just show that the cardiac function's normal.
Professor Smita, can I just add one sentence for the benefit of postgraduates?
Yeah.
When you have a person who's not very symptomatic and has an awful looking CT or chest X-ray, always think of sarcoid. Not that there's any doubt in this patient. I'm just saying for the future cases.
Sure.
It is an object lesson, isn't it? And one of the features was that the dominant abnormalities were upper zone, and they're often functionally relatively silent.
Okay. Can we move on to second case? Prakhar?
Yes, sir. So our second case, he's a 27-year-old male, a tobacco chewer and not a smoker with no comorbidity. And he had symptoms of dry cough since 2 years and dyspnea on exertion since last 2 years. And recently, around 20 days back, he had some amount of fever, sore throat, leading to incrementing dyspnea as well as the cough. So in the past, he had taken methylprednisolone 8 mg for 6 months in the year of 2024 with no symptomatic improvement in shortness of breath or dry cough. In exposure, he gave a definite history of sandblast exposure for 8 months, around 2 years back, the same timeline where he started having symptoms. Apart from that, there was no exposure history or connective tissue symptoms. On examination, he was admitted to our ICU with an SpO2 of 85% on ambient air and was initiated on HFNOT. Rate was 50, heart rate as well as tachycardic. On examination, bilateral fine mid-inspiratory crepitations, no wheezing, mostly in the basilar, although it was sort of a diffuse. He had loud P2 on cardiovascular examination. In labs, CBC, LFT, KFTs were mostly okay. His CRP was slightly high, yes, as well as ESR. His ACE level came out to be 110. Serum calcium was normal. Urine calcium was normal. ECG as well, echo, no evidence for pulmonary hypertension, and fundus as well. We cannot go ahead with our spirometry or pulmonary function testing. These are few of his chest radiographs he had from March 24 to August 24. I think
Okay.
and then we can go ahead with the HRCT. Yes.
Yep.
Prakhar, correct me if I'm wrong, but maybe my critical care knowledge is not. Why would you start him on HFNOT with an 85% say? Is that the standard now? I mean, I see some intensivists doing that. Is that what your intensivists advise?
So we started off with conventional oxygen therapy, then went off to NRBM. However, even with over 15 minutes of NRBM at 100%, we couldn't pick up his oxygen, as well as his PO2 was still less than 60. So that's why we moved over.
Okay. So you went on that route.
Yes.
Okay.
So we have only one HRCT, which is the present HRCT, and on this, on the mediastinal window, we see multiple nodes, including supraclavicular nodes and mediastinal nodes. Everything is, some of the nodes like subcarinal is almost 2 centimeters in size. And the main pulmonary artery is also dilated, so 31, which is corresponding to the loud P2. But even on CT, we don't see any RARV dilatation and nothing else in the abdomen. Some tiny calcified granulomas are there in the liver. Coming to the lungs, as we could see on the X-rays, also the lung volumes are looking less. And we see large confluent parenchymal opacities in both lungs, which are more in the upper lobes. And the extreme bases are less severely involved. There are some amount of interstitial like intra and interlobular septal thickening also. And I think there is some background fine nodularity, like if we see these kind of areas. There's a lot of pleural thickening also in the upper lobes that we can see along with the parenchymal opacities. I'll try to, we don't have a coronal, we'll just see the coronal on this just to see the, yeah, so we can see the lung volumes look quite reduced and it is having an upper lobe and little bit of central but peripheral also involved and pleural thickening also. So with these findings and all the history that we spoke about, I mean, two main things I would like to consider. One is sarcoid, especially because of the upper lobe predominance and the lymphadenopathy. And second thing is silicosis with PMF also with the sandblasting history that sir has given. So it can be like an accelerated silicosis. Those are the two main things I would think of. And I think because there are significant supraclavicular nodes, that could be a good site for a biopsy.
Okay.
And I think there is some amount of pulmonary hypertension also. It's dilated pulmonary artery.
Okay.
There are also some bits of calcium in the lungs too, Dr. Aparna.
Not much, sir. These nodes are not really calcified.
Not the nodes within the lung parenchyma. It looks like there are little bits of calcium.
No, sir, not really.
Do you think these
I
lung
can-
upper lobe lesions are like a PMF,
That will be a differential, sir.
progressive massive fibrosis of silicosis?
So I think we can then go for the questions to the panel.
Yeah, sure.
So these are my questions, rather our questions to the panel, in fact. Whether this is silicosis with PMF or sarcoidosis or an overlap, as there are few case reports published. And would there be any role for performing a lung biopsy in this, and how to go ahead with the management of this case?
Yeah,
I
so
think he's a young guy. I mean, sorry, Prala, you want to go ahead?
One more thing, if I can add.
It's a young guy with a very severely breathless, progressive breathlessness. It's a main, and the scan is very characteristic of silicosis. And I feel maybe a component of silicoproteinosis may be there because some features of crazy paving appearance is there at some areas. So it's maybe a combination of acute accelerated silicosis with evidence of progressive multiple fibrosis plus minus proteinosis inside. So that is, and biopsy, I don't think it's a history itself is sufficient. We don't have to do any biopsy. Yeah, this is what I feel.
If I may add one small point that on this admission, once we started him on corticosteroids, just about 40 mg of prednisolone, and then started tapering him. So he showed he showed a good response, and we recently discharged him on 2 liters of oxygenation.
When you say a good response, do you mean improvement in symptoms? Do you mean a chest X-ray showed some clearing? What did you mean?
Only the clinical response, sir.
I mean, I think there is a case not for just doing scans in case like this. We should continue to use good old-fashioned plain X-rays to look for signals of major change with intervention. Don't have to not do them and only do CT scans at big intervals, I feel. And since somebody else has got to say something, I do agree strongly with the distillation to this point. There's going to be granulomatous inflammation, and I'm not sure that a biopsy of the lungs is necessarily going to tell you it's sarcoid or silicosis. And I also was wondering about a proteinutic variant of silicosis with the very intense exposure. We're seeing a bit of an epidemic of these more recently. I think what is interesting, though, there's no reason why silica might not be a cofactor or an antigen driving sarcoids, so it's very plausible that you could actually find patients who have both silicosis and a manifestation of sarcoid. If you've got granulomatous inflammation that's distant from the chest, I think you probably have to suspect that this is really an overlap. So I do wonder about a PET scan to see where the granulomatous signal actually is. Now, I wouldn't get bothered if it's in hilar and mediastinal nodes. You get silica in those sites as well with silicosis. But you might want to know if there's widespread granulomatous change on a PET scan. I don't, however, see that you've got any choice but to manage this for sarcoid in this case. And when you then say your initial treatment has given you a response, I think you need to know exactly what you mean by a response. Change in lung function, or maybe he can do lung function now, and you will actually say that's an improvement. Change in imaging, but using good old-fashioned plain chest X-rays. Just quantify what is happening exactly when you treat, because you're going to use the signal you've got to devise a long-term strategy, aren't you? You're going to say, we think there's a response to sarcoid management, so we'll go on with sarcoid management and we'll optimize it.
Okay, sir. So that would mean that we presently treat him with, as a sort of a case of sarcoidosis over a period of 6 to 9 months? No?
I think many cases with silicosis don't respond to steroids, do they?
Yes.
And so the fact you think, a response to steroid therapy is really driving you towards continuing with the sarcoid management while recognizing that this could nonetheless be silicosis with a greater granulomatous element, and that's what's responding. But sarcoid management would seem appropriate in the longer term if you're actually validating that with an initial response.
Okay.
Okay.
course,
Anybody else?
Yeah,
Tell
knowing the predisposition to tuberculosis
Yeah.
and seeing that granuloma in the liver, a calcific lesion in the liver, I'd make every effort to rule out TB before we go further. But at his current state, I can't see that we can do a biopsy. He looks much too hypoxic to tolerate a biopsy.
Why not a supraclavicular lymph
Supraclavicular,
node?
yes, ma'am.
We have a big load there. So I don't believe every time we have to be heroic and go into the lung and do TBLC and all. Like Mostly that thing, and that particular point, sir, that reminds me of one case which Prahlad Prabhu Desai sir told, that pulmonary alveolar proteinosis, suspected pulmonary alveolar proteinosis, history of silica exposure in the past, and we did actually whole lung lavage to find out that gene expert was positive, and the patient was treated with ATT, TB medicines, and his everything got cleared. So it was a secondary alveolar proteinosis. So I would definitely agree that even if not a biopsy, then also BAL and expert has to be sent to rule out tuberculosis in area like ours.
Yes,
Definitely. That
yeah,
is
and in the
enough to have.
meanwhile, I would go, as Professor Wells said, to do a scan, because if we cannot conclude from the lungs, we can go to another
Anybody?
site of and to
Yeah,
use that also for
sure.
double check. And,
Sure.
Yeah. Rajan sir, you have raised hand. You wanted to say something, please.
I was actually looking for a biopsy of something else and maybe a PET scan before that. See, this guy is quite young.
Yeah.
And if this is progressive
we have
massive
to be sure.
fibrosis
Yeah.
that's occurring almost 1.5 years after exposure to silicosis,
Yeah.
um, can this fit into bronchoalveolar carcinoma, Aparna?
Yeah, I mean, we do see sometimes very weird looking ones, so I
Yeah,
can't say it's
I'm just
not.
thinking I would like tissue. I know the lung could be risky,
Sir,
and
I
I
think
think
supraclavicular node is
yeah,
the best site, sir.
yeah,
We need
that,
the tissue because he's young,
yeah,
and we have to be sure, because if he relapses or so, we have to be sure that the disease is not a cancer or whatever it is. So I
yeah.
think that's why I
Sure.
thought also.
Because as Athol said, what is the objective response? And Prakhar, if you're not going to get a good objective response to this gentleman is heading towards transplant then, and then you have problems without a biopsy or a PET scan. You won't be able to take him up, even send him for transplant, I think. So,
The supraclavicular node feels very attractive because, for a
yeah.
start, it's a rather extensive cytotoxic involvement, isn't it? Mediastinal nodes, absolutely.
Yep.
Supraclavicular nodes, well, I suppose it's possible. But if you're going to get an alternative diagnosis, it's most likely to be clear, I think.
Sure.
And then you'll culture for TB at the same time, and from the supraclavicular nodal tissue. But I agree with you, or I agree with myself and then you, that you start with a quick PET scan to see exactly what there is.
Sure. Okay. I think you got the message, right? You need a biopsy, Prakhar, from where we can
Prakhar,
decide by
is he fit to undergo a PET scan?
So he's not affordable enough to undergo a PET scan. He's
Oh.
a very poor guy.
Yeah,
So possibly I'll go ahead with a supraclavicular lymph node FNA biopsy.
Yeah. If you can't
Yeah.
do a PET scan, just feels sensible, doesn't it?
Yeah, good.
Sure. Thank you.
Sure. Thanks. And we'll move on to the. Oh, this is really irritating. So I'll move to my case and then Murli sir's case. So this is, yeah, this is just, I wanted to discuss mainly for radiology, nothing great in the case. So she is 31 years old lady from Maldives, works in office, no non-comorbidities, had history of COVID infection in 2021, no history of exposure to smoke, biomass fuel or pets or birds. Her current illness started for last 2 months, initially with dry cough and now little bit of productive cough. She had fever before that cough started. She now says that she has shortness of breath for last 3 weeks and she can walk only a short distance like 100 meters without feeling breathless and loss of weight for 2 kilogram. She has one episode of mild spurious hemoptysis, which I won't be too much worried about. And her saturation was 96% when she came to me with heart rate of 108 and BP of 103 by 71. And she didn't have any CTD stigmata. Her CRP was 5.5. This is one of the patient where I'm sorry, but I didn't send any CTD workup because I didn't feel whether I should send or not. The reason I'm discussing is because of the classical CT picture. Aparna, can you please share?
Yeah.
Yeah.
So this is present CT, and we are seeing multifocal areas of ground glass opacities. Some of them are like in kind of like arcades, and they are both central as well as peripheral, and all lobes are involved. In the upper lobes, it's little more central kind of involvement, and lower lobes there is peripheral involvement also, and some of them are like almost like that reverse halo where we can see peripheral kind of ground glass density and the central areas are clear. So the same thing we can see on the coronal also. There were so we can see that like one halo of ground glass with the central areas are a little bit clear. There was no significant lymphadenopathy and pulmonary artery was not dilated and no other findings in the rest of the abdomen or bones. So I think the imaging findings are kind of very typical for an organizing pneumonia. And
Yeah, that is what. So very classical. I actually felt that coral reef appearance kind of thing. So so
now, whether the CTD is secondary to that fever that she had, I mean, sorry, whether the organizing pneumonia is secondary to the fever that she had, like secondary to infection, or but should we do a CTD also because it's an OP pattern?
yeah, actually I wanted to admit her for other investigations. So um, my questions are like whether we should work up her properly for CTD, everything, like not only CTD. I usually start doing with a pet and all, but should I overdo that much, or because she has sudden onset of cough? CT is classical of cryptogenic organizing pneumonia. However, I have to rule out other causes before saying cryptogenic. So what should I do for such patient like FOB, BAL, TBLB? Should I do biopsy to prove this is cryptogenic? Full CTD profile, rule out other causes. As I told, I usually start even doing PET also. So, considering her young age, should I just give her a short course of steroids and do investigation if it reoccurs, or should I do all investigations? Like this is first time presentation, so I didn't do any investigation. Actually, I wanted to discuss and then I will start working up. That's what I thought. She is
Uh,
relatively asymptomatic other than dry cough.
I wouldn't,
Can
I don't
I
know
add,
why you, sorry.
Suji, you go first.
Yeah, so
Yes,
Asmita, I just don't know the logic behind doing a PET scan here on the first time.
sure.
I think you could easily treat her with prednisolone as a viral organizing pneumonia and watch for the next episode. Have you done a lung function, Asmita?
Lung function also I didn't do because her X-ray was abnormal. They and she was coughing. We didn't do.
And she's not hypoxic or anything, right?
96 on room air,
Yeah.
108 heart rate.
Because if you're going to give her empirical steroid, which may be a good idea, alongside that, do the autoimmune workup if you find
Okay,
anything
okay, yeah,
systemically that could point towards that.
considering
You'll have
this.
a baseline to go by and some objective evaluation as you go down the line. Um, I don't know whether I would do a biopsy either PET
Mm,
or biopsy. I would do nothing, to be
yeah,
honest, except the non-invasive workup
CTD and all, yeah,
and the CTD workup. And if something flags there, then decide on. And in fact, the CTD something flags again, you don't need a biopsy.
yeah.
Neither do you need a PET. So that's all over to you.
Do you mind putting the imaging back on the screen?
Aparna, can you please put the images once again for him?
I
Thanks.
just want to look at something. So we're talking about
Yeah,
effectively what is called an atoll sign, right?
yeah, you like it, right?
Yeah, but what I normally expect to see is the island around the atoll as well as the atoll. And where I feel slightly insecure, I will say this plainly, that this sign you tend to get the consolidation is the island and the atoll is the middle. Now there's a touch of consolidation out on the edge, but I'm alive to the fact that this sign occurs in other contexts, and that includes vasculitis. So the moment you say that there's anything about it that's a little atypical, I feel kind of a little more secure if you've broadened your differential. Now, that might be wrong. It may be that in the confines of a referral centre, I'm seeing those variants of the atoll sign which do have perhaps longer standing disease, perhaps they have more obvious consolidation as a rim, and I suppose there is some increased density as a rim, so you may well be right. I suspect you probably are, but I would be inclined to broaden the tests a bit, just instinctively. If there's anything about it that seems a bit unusual, and vasculitis would be a bad diagnosis to miss. So send me the serology for a vasculitis and the urinary sediment, and whether you actually go further depends entirely on what you find.
Another very good reason for doing those is she is from the Maldives. You can't observe her as frequently as you'd like to, and she goes back and gets into problems, to be a sad miss.
Yes,
ironically, we've had Professor Atoll comment about an atoll sign for a lady from the land of atolls. So
he will always love to discuss about atoll sign. Yeah.
No, and this lady's from the land of atolls.
Okay. So no, the reason I discussed was like, is it necessary to do biopsy to prove organizing? Not necessary. And I just have to do CTD workup. The reason is sometimes, na, sir, myself and Mithun have seen that organizing pneumonia can be a presenting feature of some kind of lymphoma or malignancy also. But I agree with you that for her, I need not do PET CT in the first stage itself. Like I was just telling that it is one of the part of my workup for organizing pneumonia. We'll move on
CTD and vasculitis workup.
Yes, I'll do that. I will do that.
Vasculitis workup, and your diagnosis, if you're not getting histology, is the combination of what you have and documenting disease behavior with steroid therapy and seeing there's absolutely nothing in the course of disease that makes you question the diagnosis. So I think it's one of those things where you're discussing with the patient because she is remote. So I think you might end up doing a biopsy just for that reason. And it might be a transbronchial biopsy taken from the middle of an area rather than something more invasive. I'm just factoring in what you said, that she's going off to follow up, which won't be complete. I wonder whether that's enough to make you say, well, maybe age considered and slightly atypical features on CT, perhaps. I'm not saying I know that for sure. I'm just saying the breadth of what I've seen with the atoll sign doesn't quite look like that. There's more rim of consolidation usually. So maybe you end up after conversation with the patient agreeing that perhaps the right approach is a transbronchial biopsy taken from within that area. And maybe if she votes against it, you're making a deal that there's got to be really rigorous follow-up in that case.
Sure. Okay, but just to clear my doubt that if it was alveolar hemorrhage, even BAL will clear that doubt, right? Do I really need to do transbronchial lung biopsy to prove that it is?
The vasculitis won't be alveolar hemorrhage. It will be that form of vasculitis which has infiltration rather than bleeding.
Sure. Okay.
And
okay, got it. Murli sir, your case. Gautam is presenting, huh, Gautam?
Good evening, ma'am. Yes, ma'am.
Yeah, please go ahead.
She's a 54-year female. She's symptomatic since 2011. Dry cough and functional class 2 breathlessness, but no history suggestive of CTD, weight loss, or PET exposure. She's never smoker. No family history of asthma, CTD, or malignancy. She's right mastectomy done and not sure about the cause. She doesn't have documents. She's not aware of that. And she's been treated as HP with home oxygen, tapering dose of steroids, and methotrexate since 2017. In view of worsening of symptoms, methotrexate stopped and MMF was started. In November 2023, her symptoms improved with MMF marginally. December 2024, so she came with she presented with features of core pulmonary and increase in oxygen requirement. So during the course, she was not willing for lung transplantation discussion at any point in time. CTT workup, ANA profile, CNCA, PNCA, rheumatoid factor, ESR all were negative, and whole genome sequencing negative for major mutations, but multiple heterogeneous variants of uncertain significance has been detected. My studies profile MI2 alpha was borderline and anti-Q Q was 1 plus, and used abdomen just HUN, no angioedema lipoma or anything. Looking at lung functions, FEV1 to FVC ratios 105. Comparing a lung functions which is almost relatively preserved, and from 2017 to 2024. FE1 from 2017 1.9 1.66 71%, FEC 74%, and comparing to August 2024, FE1 is 76% and FEC is almost 80% predicted. And DLCO is 12, but DLCO is very low, 12% predicted with KCO of 21%, and RVTLC is 89%. So we want to review a CT.
Sure.
So this lady was neglected herself between 2011 and 17. She also has a family history of similar disease. One of her sisters apparently was diagnosed to have sarcoid or some other parenchymal lung disease and died of the same. She's a bit terrified of that, but still, I think chose to ignore, the problem, hoping it'll go away. I've been seeing her since 2017. She's been steadily getting worse, not really responding to treatment. The first CT done in 2017 just showed extensive ground glassing, which looked like there were some areas of sparing. It wasn't a classic triple density sign. Unfortunately, she's lost that CT. Dr. Parna, over to you.
Are you muted, Aparna?
Sorry. Yeah,
Yeah,
I was muted. Yeah, so this CT is from August 2024, and we are seeing in the upper lobes multiple like bullae or cysts, which are in some form of clusters. It's little more in the right upper lobe, and lower lobes are also showing multiple small cysts or bullae plus or some kind of traction bronchiectasis also, and a lot of ground glass is also there, I think. But unfortunately, there's a lot of movement artifacts and little
yeah.
difficult to say what exactly is happening. But I think despite that, there is some ground glass and some reticulations and traction bronchiectasis. I'll show the coronal also. So this is the coronal. So we can see that similar thing, like some clusters of bullae in the upper lobes, and lower lobes is a lot of ground glass and a little bit of reticulations and traction bronchiectasis is what I'm thinking. So she has had the mastectomy. There's no lesion there. Left breast is looking normal. There are no other lymph nodes, and there's nothing to suggest any metastasis anywhere. Pulmonary artery is quite dilated. It's around 33 millimeters, and there is significant RARV dilatation also. Yeah, so these are the main findings that we are seeing now. Liver is showing some amount of volume redistribution, so maybe there is some degree of a little bit of a chronic liver disease. Lymph nodes are also there, which are again difficult to see because of a lot of movement, but there are some borderline type of mediastinal lymph nodes. So if you see the overall lung volume on the CT, it's not for the amount of whatever we see in the lower lobes, it's not much reduced. So whether I was thinking whether it's a combination of like a CPFE, whether there is a some emphysematous component and an ILD component. But yeah, it would have been nice to see the previous and maybe whether anything is different now also, and whether these ground glass was at a time when she was having anything acute happening. I'm not sure those things.
History-wise, there's been nothing acute. It's been a steady
Okay.
decline over the last 7 years that I've been seeing her.
Okay.
Strangely, her lung volumes, as Dr. Gautam presented, have been preserved, but her DLCO is right down in its boots. She desaturates very easily, is on 24-hour oxygen right now. She continues to work. She works in government, and she's now, unfortunately, has started having near syncopal episodes when she exerts herself. Yet she's absolutely adamant that she will not have a lung transplant. So really the questions are, what kind of diffuse parenchymal lung disease is this? Second, is there an element of obstructive airways disease emphysema? Because that's what we discussed at our MDT2.
Yes.
Her alpha-1 antitrypsin, if I remember right, was negative, checked in 2022 or so. And finally, any other solution. She's been on methotrexate, she's been on MMF, and we don't have a very definite etiological diagnosis.
Sir, she was not on any chemo or anything, no? So that mastectomy, like whether any drug induced, do we need to consider? But I mean, it should not go on if it is drug induced. If there's no drugs now, it should stop. But
No, to my knowledge, she didn't have anything. She doesn't remember. She only remembers she had a mastectomy and does not remember the treatment subsequently. I'm fairly sure she did not have radiotherapy.
okay.
So I missed the start. She's a non-smoker, right?
Yeah.
Non-smoker, no exposure to passive smoke either.
It's very difficult to view it as anything other than those areas as emphysematoid destruction. And especially as you are able to say that she started with ground glass evolving to what appears to be emphysematoid destruction. So if you're using your rule of thumb, the 3 scenarios where you get gas transfer in your boots with preservation of volumes, if this is a CPFE picture, it's obviously not smoking related, and you're very suspicious of immune dysregulation. In the cases like this that are unclassifiable and headaches, you always think of a weird vasculitic process. Actually, the other scenarios of emphysematoid destruction, you see it in rheumatoid lung and non-smokers, to a lesser extent in scleroderma lung. You can get a bit of emphysematoid destruction in sarcoid, you certainly can in HP, but none of those appeal for this scenario. And that DLCO is pre-terminal. I mean, I don't see too many people who are alive with a DLCO of 12%. So she may be at work, and it may be that's because it's moved so slowly that it can get down to that level. But she's just a hair's breadth away from dying, isn't she? With a DLCO of 12%. So the other 2 scenarios don't really appeal. I mean, obviously pulmonary hypertension by itself can give you that sort of profile, but you've got to factor in what's going on in the interstitium when you do that. And so I think that's a consequence of bad disease, but it's not driving the lung function pattern evolving from its early stage. I mean, because you can't explain all the interstitial findings by making pH the driver. And then there's the business of very fine abnormalities that don't move the volumes down, but move the gas transfer down, but not to this level. You know, the sort of thing you see with non-fibrotic HP, where you can get surprising preservation of volumes. I mean, even pneumocystis pneumonia can drop the gas transfer selectively, but not down to 12%, and not with a scan looking like this. So I think it's got to be emphysematoid destruction based on immune dysregulation. And I'm really just giving you likelihoods because this isn't classifiable. This is officially, I think, unclassifiable ILD. But we've got to think about the pathway driving this and a form of vasculitis. And the trouble is, it's so severe, you're quite right, it's transplant. Nothing else is likely to rescue this.
Yeah.
Also, Aparna, when you say redistribution, and I see this often on CT reports in the liver,
Yes.
what do you mean by that? Is this congestive hepatomegaly because of cor pulmonale, or is this cirrhotic features? Or?
Yes. No, it is more like a cirrhotic features. Congestive hepatomegaly, I mean, it could be secondary to the cardiac cause. Basically, what we're saying is the left lobe is becoming bigger and the right lobe is becoming smaller. That is the redistribution of the volume.
Right.
And if you see the surface, it's having a little bit of a wavy, irregular surface. So basically, it is like a cirrhotic liver, not like a congestive. Congestive would have been enlarged and
Sure. Sure.
Yes, but it could be secondary. It could be a cardiac cirrhosis also. We don't know what type
Sure.
of cirrhosis because there is RARV dilatation, but now it is like early cirrhotic phase.
Thank you.
Right. Thank you. So back, I'll tell her we've discussed it with some of the best minds, and they all believe she should have a transplant.
Sure.
And let's see if she accepts. And then we'll
Okay.
have the rest of her lung to do histopathology on. So
Well, yes, in the near future. I mean, the whole business of attacking a vasculitis with IV cyclophosphamide, my fear is that the train has long ago left the station here. And I think it's so unlikely now at this point that you'll achieve anything much you can reverse. However, if she's not going to have a transplant, I suppose that is your last throw of the dice. Can you shift the DLCO up to say 20 to 25% with really aggressive empirical vasculitic therapy, which will cover other forms of immune dysregulation?
And Dr. Mithun, you know, those myositis 1+s, do you think we can use that as an excuse for giving her something like Rituxan?
No, sir. I think like in previously also we have discussed this 1+ positivity, very difficult. It's likely a false positive. The immunoblot, Western blot techniques are very well prone to have this type of mild positivity. We cannot take it as a significant value.
I decided to ignore it, but I want some excuse to treat her with something stronger since she's not responding to anything.
And I wonder whether you want a hepatologist opinion, because even if you send her for transplant, Murli, are you going to also do a liver transplant at the same time?
That's true. Her lung function right now, I'm sorry, her liver function right now is okay.
Right.
But I agree with you. The process has set in, and
Yeah.
we will need a hepatologist to clear her if she ever agrees to go for a transplant.
Sure.
Tough one.
You all, yeah.
So
So
case
this,
5.
yeah.
Yeah.
Thank you. Thank you. This lady, 59 years old, staying in Udaipur, earlier in Mumbai, where she had pigeon exposures at a temple for about 10 years. She's also hypertensive. She came with complaints of chest pain and back pain, occasional NSAID use for the last 4 years, no cough, and mild exertional dyspnea for the last 6 months. A lifestyle largely sedentary, except for some housework in her village home near Udaipur. And she had bilateral inspiratory squeaks on examination. She's not clubbed. Her ANA is 1 in 200, fine and speckled. dsDNA, ANCA's ANA, and myositis blots were all negative. Because of a CT picture, we got a VEGF-D level down, which was normal. ESR 50, rheumatoid factor was positive, CPK 41, CCP negative.
Yeah.
And this was her lung function. So she's quite compromised when she's come to us itself. But because she has hardly any symptoms, she's, I think, getting on with her life, sedentary life in a smaller town definitely smaller town than Mumbai. So 39.8% vital capacity, DLCO 37.8, and she's desaturating to 84 with no dyspnea, which correlates with her history. And that was the ANA blot and the myositis blot and her scans. Yeah, Aparna?
Yes, sir. So these are our inspiratory and expiratory scans are there, and this is from this month itself. So what we're seeing is the predominant finding is multiple cysts of varying sizes. Some are quite large, and the larger ones have some thin septations within them. They're everywhere, including like paramediastinal. There are cysts. There are subpleural cysts. Some of them are perivascular, also close to the like. Some of these are perivascular. Many of them have this internal small septations. And another important finding is the background lung is not normal. There is definitely a lot of ground glass densities in the background lung, which we're seeing on the inspiratory scans also. Expiratory scans is exaggerating whatever we are seeing on inspiratory, and there are some areas of air trapping on the expiratory scans. But in spite of that, I think there is definitely some background ground glass density in both lungs. There are no nodules anywhere, and there is no other features of any fibrosis. Her kidneys were normal. There was no angiomyolipoma or any other lesions. And mm, yeah, she
The-
had some small lymph nodes only, some 9 to 10 I'll just show the mediastinal window. So, main pulmonary artery is not dilated, and very small volume mediastinal nodes, which are probably just some reactive nodes. And yeah, kidneys are normal. Liver has one small calcified granuloma. And there was some small, like one fat attenuation area in the interventricular septum, which can sometimes be just normal, or it could be some old infarct or something like that. But LV size, heart size looks normal. So the putting together the findings, mainly it is multiple cysts along with ground glass opacities and probably some areas of air trapping as well. So the things that we can consider now is because of the combination of cysts and ground glass, I think LAM is unlikely because of the ground glass. One thing is the history is long-standing, no, sir. So it's not like acute history. So I mean, other things that can cause cysts with ground glass will be like pneumocystis. But because of the long-standing history, that we will exclude. Uh, the other things will be hypersensitivity, because we are seeing some areas of air trapping, and we could get some cysts in hypersensitivity pneumonitis. And LIP will be the other thing. So I saw all the Jogren's tests were also negative, no, sir. But should we still check any HIV or anything? Those things are the.
Sjogren in this case we cannot rule out because rheumatoid factor is strongly positive.
Oh,
Yeah.
okay.
101 and 30% of the Sjogren can be anti-SSA negative. Her ANA is positive, no? ANA is 1:200
1
positive.
in 200. That's
That is
right.
a pretty good titer. Therefore, she still fits. We can strongly suspect primary Sjogren syndrome. Ideally,
Then
we
I
have
think
to.
LIP will be the top diagnosis here then.
Well,
Yeah.
would on the CT,
Yes, sir.
because the case you're making, I mean, it's obviously not going to be LAM.
Yes, sir.
And the only differential I can come up with, which you did too, HP, I don't think you see cysts as profuse as this and severe as this in HP. Sure,
Yeah.
you can get cysts, but not generally looking like
Yeah.
this.
Yes.
So even before we heard the other arguments for LIP, I think you're starting with a high pre-clinician likelihood of LIP when you look at the scan, and then everything you're saying about suspecting Sjogren's on other grounds, including the serological profile, you haven't excluded Sjogren's, just makes a lot of sense. But even if you were to exclude Sjogren's, there is such a thing as idiopathic LIP. Have you thought of, well, maybe you actually find out if there's Sjogren's first of all before you think about any other investigation, because if you nailed Sjogren's at this point with this scan, is there really any differential of what's going on in the lungs?
So what Bhavin reported, because he had multiple scans from 2020, which were only on film and not soft copy, which Aparna, I don't think has, right,
No,
Aparna?
sir. No.
Yeah. So what he's reported is compare it with the first scan of 2020, shows progression of both the fibrotic and non-fibrotic components, but with no significant change in the number of cysts, with minimal increase in their size. So does that give any clue to Sjogren's versus HP?
It doesn't to me. I mean, was Bhavin favoring HP on this?
Yes. He favored HP, saying that the fibrotic, non-fibrotic components were progressing from 2020, She was getting
Yes.
scans done, but the cysts were just the same as they were in 2020.
Let me say that if Bhavin has experience of proven HP with cysts of this size, I defer instantly to his view on this. I'm giving you my perception, but let's face it, radiology isn't my day job. But it did strike me as a little unlikely, but if he's seen that and knows that to be so, we must accept that.
No, but
And
he has
therefore,
added the rider Athol that assuming
yes.
there is no underlying connective tissue disease. He has added that in his report.
So all roads lead to evaluation of Sjogren's syndrome then.
Okay. Okay. I mean, with serology and all negative, so I did get
Not
a
entirely
rheumatologist.
negative.
Yeah. So the rheumatologist who saw her said that, well, she didn't think of Sjogren's here actually. She said to add mycophenolate because it will help both RA lung and HP. So what would you suggest, Mithun?
We need to evaluate for Sjogren. First, history-wise, you have to ask for the Zika symptoms, especially dry and mouth,
Right.
and we have to do a Schirmer test. And
Okay.
ideally, we have to go ahead with a lip biopsy.
Yeah.
Yes, the
Lip
lip
biopsy.
biopsy. I think we have
Okay.
to do the yes, I would like to say that.
Safe.
Super.
I also agree with that, actually, that if Sjogren's is negative, you absolutely have to decide based on histology whether this is a form of HP or whether it is LIP.
Right. Because we have given her no treatment at all. We haven't offered her any treatment. Sharma's, I will revisit this with Nina Chitnis. You know Nina, Mithun?
I heard of, no, I don't know.
She's the rheumatologist involved, so I will tell her about Sharma's lip biopsies and of course.
Dr. Rajan,
And
just for my interest, I mean, would
Yes,
you mind
Amila.
letting me know what is the ANA staining pattern? Is it cytoplasmic or nuclear?
I think it was fine and speckled, right, Asmita, on the slide?
fine speckle, no?
Fine speckled.
Right. Thank you.
They're not given the intensity, they have given the titer. Some labs give like that.
Oh,
Some labs give like 3 plus, 2 plus like that. Some labs give the titers.
all right. Okay. Thank you.
And ESR is also high. Any hyperglobulinemia? Usually Sjogren can have
I haven't checked that. I can check serum.
IgM will be high, right?
Yeah.
IgG.
Dr. Mithun, usually it is cytoplasmic, isn't it? When the in Sjogren's you get cytoplasmic as
No,
well.
no,
When the ENA panel is negative.
nuclear speckle pattern.
Right.
Classically,
Yes,
nuclear speckle. Cytoplasmic can also occur, but classically it is a speckled nuclear pattern.
There's
Right.
one more feature in the clinical summary, actually, that is highly relevant, and that is bilateral inspiratory squeaks.
Yes.
And
Yes.
Yeah.
in the days in which I used to use my stethoscope rather than a CT scan, I never heard inspiratory squeaks in an LIP case.
Okay.
It really was pointing towards HP. So I think that I'm at a 50-50. You take aboard what Bhavin said,
Yeah.
plus the inspiratory squeaks. This is the serological clues. I think we're finely balanced once you see the inspiratory squeaks.
Sure. Sure. No,
Okay.
that makes sense. Maybe she was also not thinking of Sjogren's when she read Bhavin's report, but she so I don't think a lung biopsy here. I mean I don't think she's going to agree to one anyway. But that was a question I had.
Yeah. So
Sujit, I'll remind you, she comes from Udaipur, epicenter of hypersensitivity.
Yes.
yeah.
Yeah. I think that's why Bhavin signs off on that first and then puts the rider for CTD.
Yeah. So
Thank you.
last
Thank you. Very
case, which
useful.
we can just sum up fast. This was already discussed last time. She was 33 years old, staff nurse from Ireland who relocated there in 2018, but started having symptoms by 2019 January itself and visited India somewhere in September 2019 for the checkup. She came to us. She has history of lovebird exposure for 4 years. That was 20 years before, and she came here for second opinion for lung transplant. Her main complaint is recurrent episodes of cough, dry cough, and breathing difficulty. Presently, she is on 2 to 3 liters of oxygen. On room air, she is maintaining 92, but 98% on 4 liters of oxygen. I could not do her PFT or DLC or anything because she was continuously using oxygen. Her connective tissue workup was negative. We could not find anything positive in other investigations also. These were done in Amrita, which were also found to be negative. This was her last test which was conducted outside, and her echo and right heart catheterization was not showing pulmonary hypertension. So with that background, I would like Parna to show the CT scan images. Why we are discussing this was last time it was discussed that 2024 and 2025 CT scan didn't show any significant change. So most probably it is COVID. 2021 was the time when she started using oxygen. So Professor Atholwell suggested that maybe the immune dysregulation which happened during COVID time would have caused predominant worsening. But we had her images in 2019 when she didn't have COVID, and that is why this case has been discussed again. Yeah.
So this first set, this is the 2019 images. So already in this images, we are seeing that there is fibrosis with subpleural honeycombing. So upper lobes anteriorly some involvement is there, and lower lobes there is a lot of ground glass, some reticulations, and again at the bases there is mild honeycombing. It's a little asymmetric. Right lung is little more involved, but left lung is also having few areas of focal honeycombing. So this was in 2019. So this, I guess this is September 2019.
Yeah.
So after that, we have two CTs which are in 24 and 25, where the fibrosis and that honeycombing and the cysts are looking almost similar, maybe some mild worsening, but lot of increase in the ground glass and reticulations. And there's a little bit of difference in the technique between the 24 and 25 CT. But yeah, it is actually not showing too much difference between the two, but I guess it is showing some mild worsening.
Yeah.
I think when we discussed it, we knew there were symptoms before the COVID, but the worsening seemed to accelerate immediately following the COVID. So the issue was more whether the COVID might have amplified that we were in a situation with a combination of factors. And it's very clear now that we can look at the scan before COVID and try to conclude what there was and give it a label if we possibly can. So my question now to the radiologist is, what is the diagnosis in 2019 based on the scan?
Yeah, I think mainly what we're seeing is these are areas of honeycombing plus little bit of reticulations and ground glass. I would have thought of like a probable UIP, and because this anterior upper lobe, etc., and young lady would have thought of a CTD ILD, I think at that time.
I think that is what Bhavin sir also told, that classical CTD ILD picture, but we don't have anything positive coming. That is what sir also told, that the workup is not coming positive, but Baki she has got anterior upper lobe, four corner side, everything is there.
And
So
she's not being given more steroid or anything recently, right? She's on this maintenance dose of 5 mg, right?
yeah, 5 milligram and MMF. Yeah.
And MMF is what, 360 BID or something like that?
I'm not sure. I don't remember. 500 BD or something, and
Yeah,
she received 2 to 3 doses of rituximab also, but it didn't help her. That is
it
what
didn't
she
help
still,
her.
yeah, she was never given antifibrotic, and she's herself highly motivated, and there are people who are motivating her for lung transplant. So the discussion is about that sir told that we should wait for 3 years at least for
Prahlad
deciding.
wasn't there last time. Prahlad, were you there last time?
Yeah, I was there for this case. Yeah.
Yeah,
Yeah.
so four years she's been waiting for a transplant. And if you look at her, she can handle a conversation very comfortably without oxygen. She's 92% on room air.
She
So
traveled from Ireland to India and from
yeah.
Calicut to Kochi via road, which takes at least 6-7 hours, and that's really like it. I will be worried about if I am going from Calicut to Kochi via road. So you are right, sir. Yeah, it's really a kind of thing which we
And then
cannot explain.
we did discuss last time, what Athol mentioned is that with a best case scenario on transplant, 60% 5 year survival. And she's now what, 32 years old or
33,
33?
yeah, 33.
She's
That's
now
it.
33. Prahlad,
Yeah.
would you push her to transplant, Prahlad, if she was motivated and her family is motivating her? And of course, the transplant team is motivating her.
Yeah.
I I think currently this is not a time for referring for a transplant. She is not on oxygen therapy. She is doing her day-to-day activity. I feel we should wait. Yeah, we should.
She uses oxygen,
She
but
uses
she
it.
doesn't need it if she sits quietly at rest. She doesn't need it.
Yeah.
Yeah.
Yeah,
mean,
and
it's
actually, Murli sir suggested that panic attack and also most of the time she told that whenever she will have a bout of cough, then she will feel that she can't breathe at all, and then she has to use oxygen. So that
So
was the thing.
we were planning to do an online consult with her early week or sometime, with the transplant team and give her and see whether she, takes a decision after that, either way, what she'd like to do. But I'm wondering whether if she was not motivated for a transplant, I would never have thought of sending her for transplant. Now that she's motivated for it, and
To say no, yeah.
to be 4 years on a waiting list in Ireland and travel to India, I mean, I'm just wondering whether she could remain stable for a few more years before we send her for transplant.
Well, I think it is important that there's no change in the last two scans, isn't it? And ironically, if either scan had been done, say, in 2021, you would have been saying she should go to transplant because you would have been seeing 2019 to 2021. It's also interesting if you're calling UIP on the first scan, that what you then see with progression, an awful lot of it doesn't really look like UIP.
Yeah.
So
Yes.
I quite like the idea there's an immune dysregulation with a mixture of processes going on, but the point is they appear to have burnt out. And it may be the COVID accelerated everything and the COVID impact burnt out. So it was an add-on. So I don't think that what we've seen changes our view from last time, basically.
Sure. Okay, so we will observe.
Yeah.
Mm.
The other question is whether to escalate treatment and make an attempt to reverse anything there. My instinct is you might not work very well in so far as you see scans that are identical. Is that a year apart?
Yeah.
Yes.
So
It was discussed about antifibrotics also to start nintedanib or something like that. Should we do that? She
Yeah.
has never
well,
received.
I'd rather start nintedanib that send her to transplant
Yes.
if given the
Okay.
choice.
Okay. Okay.
And there is a case for that, actually. Now we've reached this point because we know there was a process with some fibrosis that preceded
Yeah.
the COVID. And we've got a snapshot, but the oxygen saturation is now closer to the steep part of the oxygen desaturation curve. It's one thing to take her to transplant and give her a mortality. It's another thing, isn't it, to cover the possibility of progression with nintedanib. I would be inclined to add nintedanib.
Sure.
But we should vote on that, really.
But Aparna, do you think the latest scan would justify, say, a little bit of pulse steroid and see the response to that? Or is that all motion artifact on the latest scan?
She doesn't want
No,
steroids.
sir.
She,
Yeah.
one thing which she is very clear about is she doesn't want steroids. That,
You mean more steroid?
yeah,
No,
so she was on steroids, 20 milligram, and like one thing which she specifically told is she is really concerned about her looks.
Yeah, but you know, she's going to be on much more steroid after transplant, Asmita.
exactly.
So, you
Yeah.
know, it doesn't make sense, you know. So my point is
Well,
that there's so many patients who say they don't want steroids and they need to be counseled on it.
Yeah.
I'm just wondering,
Yes.
give her 500 mg a pulse for 3 days and see whether she gains anything, you know. I'm
I
Yes.
just,
strongly agree. I
Yes, there is
strongly agree.
definitely a lot of ground glass.
yeah.
Only thing is, it's been there for a year, but it still looks like it may be active.
Irreversible, yeah.
Yeah.
Dr. Aparna,
That's
is
the
there
only.
a much thicker section?
These are a little thicker sections. I don't have actually any thinner. This is the one that is available for this CT.
So that kind of confuses the picture a little, doesn't it?
Little bit, but I think it's more or less there. Yeah.
Look, you're using steroid as a test, really, aren't you?
Yeah,
And
yeah.
just 3 days of steroid, and you're not then leading into more steroid, but you're saying, is there a reversible element? And then target it with non-steroid therapies.
Yes.
So I think that's very reasonable because I'm not sure prostmethylprednisolone for 3 days is going to change her looks.
I know.
I agree.
Yeah.
And she needs to be counseled on her looks after transplant also, I think. Someone's
Yeah.
got to talk to her.
Okay, sir.
It's not going to be an easy journey, which is what I think. I don't
Nobody
know.
has explained her, yeah.
I'm not sure how much they've explained her that, yeah.
Yeah. Okay, I think that's it for
Thank you.
today.
I think the other thing is you're using nintedanib with more confidence if this is completely
Yes.
resistant to methylpred, because you're then saying this is entirely irreversible, and any shift down is likely to be a big problem for her.
Sure. Okay.
Thank you.
Thank you. I think that's it
Thank you.
for today.
Thank you. Thank
Thank
you.
you so much, everybody, for being with us. And the next meeting is on 7th, right?
That's right.
Yeah,
My
7th.
apologies for that. I'll be flying to Chicago at the time. My travel has been diabolical. It's always on Fridays I'm traveling to things, so
Sure.
sorry to miss next one.
Yeah, I believe that in 1 year of our MDM, you will be finishing one world tour, right, sir? The way you travel.
Okay, I've got to race to an airport now, so
Sure.
I'll go to say
Thank you.
goodbye.
Thank
Bye.
you.
Thank you.
Yes,
Thank you,
bye.
Smita.
Have a nice
Thank you.
weekend.
Bye.
Thank you,
Bye.
Katrina. Bye. Good
Bye.
night.
Bye.
Good night. Good day. Good day.
Bye.
Thank you, everybody.
Prahlad,
Yeah, बोल ना.
what would you do if she was very keen on a transplant?
Start the
Very
interview.
rarely such patients are keen on transplant, but we should not demotivate her. And we should prepare her for transplant. You're right, actually. And as I know that the thing is that generally we talk that if people go walking for a transplant, they will come walking.
Yeah, I know. So that's what I think. She's in that mood, you know. She's just come for it like it's a laparoscopic cholecystectomy, you know. That's the whole problem, right? It's not. I'm trying to tell her that, but the transplant team is also ringing me up now. Ki kabhi bhej rahe. So, so
They would like to have such patient who are highly motivated,
yeah,
and
that's true.
maybe she get a priority actually.
Yeah, because of her age. Yeah.
Age. But your idea of thought of giving a pulse solimedrol is really fantastic. But I would do one thing, prior to giving a steroid, I will do a lavage on the right base. Okay. And
Yeah.
do a lavage, bronchial lavage, and cell counts, etc. Get a lot of things, the other microbiology workup also, just to see, and especially cell count cytology, and then afterwards pulsing.
Pulsar. Okay. I'll tell Asmita that. I told because Asmita has only seen her. I've only seen her online. I
Okay.
said we will consult her together on that. She's all charged up. She sits in the middle and two relatives on the side. कभी करने का है transfer.